also did realize I didn't actually introduce myself, and some of you do not know me, so I will introduce myself quickly. My name is Lee Frame. I am the Executive Director of the Office of Integrative Medicine and Health. So that's what you need to know about me. I'm also a researcher by training, and I love talking about all things integrative medicine, so I'm excited to be here. And I'm really excited to talk about our next speaker. Let me pull up her bio. Sorry, my computer decided it didn't want Microsoft Word to be running anymore. Okay, here we go. We are really honored to have Dr. Helene Langevin with us today. She was sworn in as the director of the National Center for Complementary and Integrative Health, or NCCIH for short, on November 26, 2018. Previously, she served as director of the Osher Center for Integrative Medicine, which is jointly based at Brigham and Women's Hospital and Harvard Medical School, as well as professor in residence of medicine at Harvard Medical School. Dr. Langevin's research interests have centered around the role of connective tissue in chronic musculoskeletal pain and the mechanisms of acupuncture, manual and movement-based therapies, including the effects of stretching on inflammation resolution within connective tissue, which I've seen her give a talk about, and it's really fantastic. So that's another thing you've got to find on the internet is her talk about that. She's authored more than 70 original scientific papers and is a fellow of the American College of Physicians. Dr. Langevin earned an MD at McGill University. She completed a postdoctoral research fellowship at the MRC Neurochemical Pharmacological Unit in Cambridge, England, as well as a residency in internal medicine and fellowship in endocrinology and metabolism at the Johns Hopkins Hospital. As NCCIH director, Dr. Langevin oversees the federal government's lead agency that funds and conducts research to help answer important scientific and public health questions about natural products, mind and body practices, and pain management. The center also coordinates and collaborates with other research institutes and federal programs on research into complementary and integrative health. Before I turn it over to Dr. Langevin, please keep the questions coming in the chat. Dr. Langevin will actually have some time to take NCCIH specific questions immediately after her talk, and then we'll do another mindful movement break and head into the panel session. So with that, I will welcome Dr. Langevin.
Thank you so much. It's such a pleasure to be here and to have the opportunity to talk about the new strategic priorities of NCCIH around the theme of whole person health. And we had the perfect introduction to this by Dr. El-Bayoumy's presentation that really illustrated how a holistic approach to health is so important. So I'm going to be sharing my screen. Can you see this?
Yes.
Okay, good. So the NCCIH is currently going through our strategic planning process for the next 5 years. And in the process of doing this, we have been sort of re-examining the meaning of the term complementary and integrative health. And I want to illustrate this for you. Going through the letters CIH one at a time. So the first is our middle C for complementary. And the term complementary evolved from the term alternative. 20 years ago, when NCCIH used to be NCAM, for National Center for Complementary and Alternative Medicine, the term alternative was sort of a term used to describe treatments or practices that may be used as an alternative to conventional medicine. And we've been sort of going away from that. We really feel that the important thing about complementary therapies is that they can be used together with, in an appropriate way with conventional care. And so gradually these complementary practices are being integrated into the mainstream of healthcare. And we've been illustrating this with this sort of diagram here that shows sort of these major categories of treatments and practices, being nutritional, psychological, and physical, and how these overlap with some of the more traditional categories, like drugs, for example, devices or surgery. And importantly, these categories have also overlap with each other. For example, there's a considerable overlap between the psychological and the physical category. Psychological practices might include, for example, mindfulness-based stress reduction or other meditative practices. But there's also a fair amount of overlap between conventional, say, psychotherapy and cognitive behavior therapy that gradually is incorporating things like mindfulness and relaxation techniques. Also, overlap between the psychological and the physical categories in a sense that there's a lot of techniques, for example, yoga and Tai Chi, that have both a psychological and a physical component. Again, more physical, pure physical types of treatments, like manual therapies, for example. There's an overlap between that and conventional physical therapy, which is beginning to incorporate a lot of techniques derived from massage or spinal manipulation, for example, derived from osteopathic or chiropractic techniques. And then there's acupuncture, which, as you can see, sits kind of at an intersection between psychological, physical, and devices, because acupuncture needles are essentially little devices that can be connected to different types of stimulation, for example, electrical stimulation. So as you can see, and then if you look at the nutritional category, there's again an overlap between, for example, dietary supplements and drugs, because some supplements can be used as prescription, can be classified both as the same component. For example, niacin can be classified as a dietary supplement or a drug, depending on the dose used. So again, I want to point out an intersection between the nutritional and the psychological category in the form of mindful eating. So you can see that this is a complex map that is likely to evolve. But we like to think about it this way, as to show the sort of the distribution of these complementary therapies. The other important thing to note is that here, these types of therapies have been used, are listed sort of as in isolation, kind of one at a time. But in practice, very often they are combined. For example, traditional Chinese medicine, for example, used a combination of nutritional and also, for example, Tai Chi, which would be a psychological and physical, and acupuncture, as well as application of heat or cold. So you can see that what we call these multi-component therapies that can be joined together in what we call a multi-component therapeutic system that has its own sort of theory, and sometimes there's an underlying theory and sometimes even diagnostic kind of framework that ties these techniques together. And we think that these are important to study, not only in isolation, but as a system. So the kind of description that we have arrived is for the word complementary is that these complementary therapies consist of practices and systems and therapies that use dietary, physical, and psychological approaches and may have originated outside of conventional medicine, but are gradually being incorporated into mainstream healthcare. So let's move on to the next letter, which is the letter I for integrative. When we think about integration or integrative health or integrative medicine, we usually think about bringing conventional and complementary therapies together in an integrative way, and that's true. But at NCCIH, we also think that the word integrative goes further than that. And what do I mean by that? Well, whenever you have any kind of scientific discipline, even mathematics or philosophy, you always have these two sort of countercurrents of analysis and synthesis. Analysis is when you break things down into smaller and smaller components, and then synthesis is when you put them back together into the whole, or another word for synthesis is integration, right? And in conventional medicine, we're really good at analysis. Starting with breaking down the system into the body, into various different physiological systems, and then into cells, and then into signaling pathways and molecules. And this has resulted in a very, very sort of biochemical approach to understanding the functioning of the human body. And it makes sense that the overwhelming approach that is derived from this is biochemical and is basically pharmacology. Because if we think about diseases, for example, in terms of sort of molecular pathways, the way to intervene and to manage these diseases is, again, through biochemistry. But it's also important to think about how and why this occurred and why this reductionistic approach. It really started way back at the beginning at the end of the 19th century, when the various organs and systems of the body were beginning to be understood. And this has determined the structure of our medical specialties and also medical academic departments, and even the NIH, organized along organs and systems and diseases. So I'm going to illustrate this with a case history. This is a history of a 50-year-old female with type 2 diabetes. She's overweight with a BMI of 30, and efforts to control her blood sugar with diet have been so far unsuccessful. Her doctor starts her on metformin and then glipizide, which has kept her hemoglobin A1C within the normal range for the past 2 years, although her BMI is now 32. She has a 10-year history of hypertension that was controlled with hydrochlorothiazide until 3 months ago when an ACE inhibitor was added. This was discontinued 2 months later due to a persistent dry cough, and a beta blocker was added to her regimen. Her blood pressure is still slightly elevated. The cough symptoms improved after discontinuing the ACE inhibitor, but have not completely subsided. She had osteoarthritis of the right knee, managed with Motrin and Tylenol for acute exacerbation. She has a long history of anxiety, difficulty sleeping, and intermittent epigastric pain attributed to gastroesophageal reflux. She's been prescribed Ambien to take as needed for sleep and Prilosec for her heartburn. She's concerned that her GI symptoms are due to one of her diabetes medications, but was strongly encouraged to stay on these since they are successfully controlling her blood sugar. She also has slight iron deficiency anemia, which is being worked up for a GI source. And she was told to discontinue the Motrin and take Tylenol instead. Now imagine the same patient 30 years later in a nursing home. Her diabetes and hypertension are still under reasonable control with a total of 4 medications, but her insomnia and chronic knee pain are increasingly problematic. She has not been able to sleep at all without medications for many years. She's had some cognitive decline, daytime somnolence, and worsening anxiety. In an attempt to wean her from benzodiazepines, she was started on trazodone with some benefit, but has recently developed worsening tachycardia, which is being evaluated. She had a GI bleed from erosive gastritis in her mid-60s and can no longer take NSAIDs. And she has needed stronger analgesics to control the knee pain with occasional opiates for acute exacerbations. What's wrong with this all too familiar picture? The patient is suffering from having been broken down into separate body parts. And each of her problems is being treated as a separate disease. And the resulting polydiagnosis and polypharmacy create an additional layer of iatrogenic drug-induced pathology. And failure to understand the importance of seeing this patient as a whole person has led to her being treated using a fragmented, disease-focused model that encourages a reliance on pharmacologically controlling separate diseases rather than restoring health. This is obviously a serious problem. Now, what is the solution? Well, clearly what we need to do is point the arrow back towards the whole patient. But that's not easy to do. Lately, we've seen a lot of efforts to talk about both personalized medicine, individualized treatments, and precision medicine. And we also talk about whole person health, but sometimes the words get confused. The word personalized, for example, gets used both in the context of a whole person approach to biopsychosocial approach to understanding the whole patient, but also the same word personalized gets used to describe precision medicine that is aimed at specific for example, molecular targets based on genetic alleles, for example. So more and more, we're starting to understand that we need to integrate, and the fields of integrative physiology, systems biology, and genome-wide association studies are starting to move the needle back towards integration, back to understanding the systems that tie all of these phenomena together. But this is a long process. So at NCCIH, we feel that this is a very important part of what we need to do. We need to advance research, not only on the integration of a complementary and conventional care, but also we need to promote an integrative approach to physiology, understanding the normal functioning of the body, pathophysiology, and treatment. So let's now move to the letter H for health. When we think about health and we think about disease, they're not discontinuous states. There are gradations in between. And as somebody moves from a healthy state to a less healthy state, to finally to a frank disease, there is a point where some signs begin to appear of distress or of dysfunction. The patient may have a poor diet, for example, may have a sedentary lifestyle, not getting enough exercise, may be under psychological stress, perhaps they're having difficulty sleeping. And the important thing is that these common problems are really predisposing factors to a number of different diseases of separate organ systems. By the time that they are at the disease stage, that's the case of where we start thinking about them as separate problems. But if we look back to these predisposing factors, we see that the same psychological stress, poor diet, and sedentary lifestyle very much occur in the same people. The people who are very often under disadvantaged socioeconomic conditions, under the same people who suffer healthcare disparities, the same people who are disproportionately affected by coronavirus epidemic, and the same people who are also at increased risk for chronic pain, for opiate addiction, and for suicide. And so these are not disconnected problems. If we think about it this way, and we think that not only do all of these separate, what we call co-occurring or comorbid diseases have common predisposing factors, you can use the same argument to argue for an integrated approach to reversing some of these problems before, while they are still at a stage where they may still be reversible. And so an integrated approach including both self-care and multi-component interventions, including nutritional, psychological, physical interventions, such as the ones that I was showing earlier, this is how we think that we can intervene in what we call a multi-component approach or integrated approach to restore health. When we think about even preventive medicine, we are usually so much oriented towards disease that we think about it in terms of disease prevention, but we need to increasingly turn our focus towards health restoration. How do we assist and empower people to improve their health in multiple interconnected domains: biological, behavioral, social, and environmental? Now, how does this happen physiologically? If we think about pathogenesis, which is really, these are mechanisms of disease, right? And if you think about these two, I've represented here these networks. Imagine the blue network being a healthy network and the red network being less healthy. You can imagine that if somebody is moving into a less healthier state, that the red network would gradually get more and more distorted compared with the blue network. Now, what about when somebody goes back towards health? does the same process occur in reverse? And this is where the word salutogenesis is very interesting here, because if we think about, is the reverse of pathogenesis when somebody goes back from a less healthy state to a healthier state, does that kind of just recapitulate the steps of pathogenesis or in reverse? Or do some specific healing pathways, for example, need to be activated in order for the person to become healthier? And these pathways could be, they could be biological, they could be psychological, they could be behavioral. We don't know because we haven't studied it this way. And at NCCIH, we're very interested in this process of understanding salutogenesis. And we are just recently, we have partnered with several other institutes at the NIH we've issued a notice of intent to publish a funding opportunity for studying salutogenesis as part of an artificial intelligence opportunity to get, for example, researchers with an interest in various aspects of health, and engineers and computer scientists who have an expertise in artificial intelligence, because we think that in order to understand how these complex networks change over time, either towards disease or back towards health, you really need those types of very sophisticated tools. So we're very excited that NCCIH will be part of this. So just to summarize, the health, how we think about health now is that at NCCIH, we want to address health promotion and restoration, as well as disease prevention and symptom management. Of course, managing symptoms is important throughout the health span, but we want to make sure that these symptoms don't get managed in an isolated way, that there's always an eye towards improving the health of the individual. And so we think that at certainly, this is the way that we have been describing this. At an individual level, you can think about the various biological, behavioral, social, and environmental domains of health on this kind of what we call the vertical axis. And then on the horizontal axis, we have what we call the bidirectional health disease continuum, where an individual throughout their life is really kind of moving back and forth between these two states. And this is not static. An individual may, for example, have an acute illness. And for example, coronavirus, COVID-19 is a perfect example of this, where the individual may not return to health fully right away. And there's a process that is necessary in order for the person to regain their health. We really need to understand how that happens and how sometimes people who have these kind of long-term sequelae of COVID-19, why is that? Why is it that some people don't go back fully to health for a while? The same thing with bacterial infections. In the old days, before antibiotics, if somebody had a bacterial infection, a lot of attention was paid to what they call the convalescent period. If you read, novels from the 18th or 19th century, that was a critical time if somebody was recovering from pneumonia or from some kind of another type of bacterial infection. And there was a lot of attention paid to gradual return to physical activity, to diet, and to make sure that the person didn't have a relapse. Now we have powerful antibiotics where we take a course of antibiotics and then we assume that the person is going to be back to health after this. But we know that that's not always the case. And we also know that, for example, the microbiome gets very much affected by antibiotics. And it takes a while for the microbiome to recover, after antibiotic treatment. Another example is a chronic remitting or relapsing condition like inflammatory bowel disease or rheumatoid arthritis. Patients will go through cycles of exacerbations and remissions. What can we do to assist patients to, when they are in a remission, to stay in remission and prevent them from having another flare. Recovery from an accident or an injury is similar. Once the bone has been healed back together, there's still a long period of time that needs to be, and where particular attention needs to be given to rehabilitation, restoration of movement, restoration of physical stamina. These are all part of what we call health restoration. So the other aspect of this is that clearly this is not simply at the individual level. The same principles can be applied to family, to community, and to whole populations. Right now, the population of the United States is in a very poor state of health. This is documented. The life expectancy in the United States has been declining now for several years in a row. This is a very alarming statistic. And we have all of these confluent crises, converging problems that are disproportionately affecting patients of minorities and people with healthcare disparities. That is very, very troubling. And in addition, what we think is contributing to this is the fact that we have a fragmented approach to health that really looks at problems in a disconnected way, in a non-integrated way. And so we think that integration is really very much part of the solution to this. So I have kind of described to you the three components of complementary and integrative health, describe the complementary therapies, practices, and systems that are gradually being incorporated and integrated, not just with conventional care, but also integrated at every level of understanding health, disease, and treatment, and understanding the bidirectional health continuum and the two components, the two important components of whole person health, the integration in this sort of the different domains of behavioral, psychological, social, and environmental, as well as the time domain that describes this bidirectional axis of health or disease through which we are traveling for our entire lives. So I encourage you to visit our website, nccih.nih.gov. We will be posting the final version of our strategic plan very soon. We really want to thank all of the people who have contributed to this strategic plan via comments on our request for information. And also check out there's a lot of very exciting funding opportunities that we post all the time, including the Bridge to AI Artificial Intelligence projects that I mentioned. And also, please follow us on social media, Twitter, and we really look forward to hearing from you. Thank you.
Thank you. That was wonderful. And I think a really nice end to our day. You kind of wrapped everything into a nice little package with a bow. So if there are any questions directly related to Dr. Langevin's presentation, related to NCCIH or some of the strategic initiatives, you can go ahead and put them in the chat now, as we have time to get questions directly with her. And if you're having trouble typing them in, you may be able to unmute yourself and ask. That may also work. Well, while we're waiting, I know one of the things that I've always wondered about with NCCIH is how can one organization do so many things? Right? You know, integrative health is so big, and I struggle with this at GW. It's so big, and there's so many things that need to be done, and you need to have mechanisms behind it. So we need to do basic research, but then we need to know how it works in humans, so we have to do clinical trials. And how can you manage all those different priorities and still be effective?
Yeah, that is such a good question. And we struggle with that at NCCIH because we are one of the smallest centers at NIH. And the way we do this is by partnering. So we are leveraging a lot of our efforts with other institutes and centers at NIH. And we partner with, for example, the HEAL initiative. So the HEAL initiative is a trans-NIH effort that is for addressing the opioid epidemic and for improving the management of pain and opioid use disorder. And NCCIH is very much involved in this, and we have received a lot of funding through that, through the HEAL initiative for projects that are both, that address what we call pragmatic and implementation trials. These are clinical trials that are in the healthcare setting, like in the real world as healthcare is actually occurring. And also what we call implementation is very important. If we have evidence that some therapies, for example, some non-pharmacological approaches for pain are effective, but they're still not being implemented, and we still know that still way too many physicians prescribe opiates for somebody who comes in with either acute or chronic back pain, for example, when it clearly, the clinical guidelines say that you should not do that. Why is it that they're not referring to physical therapy or to acupuncture or to massage? Well, there are reasons for that, and that's what we want to study is why is this, and really address it. And the other, so that's one piece, and then there's other, for example, the Healthcare Systems Research Collaboratory, which is another very trans-NIH initiative where we partner with a lot of institutes, National Institute on Aging, Child Health and Human Development, and nursing, for example. And so we really leverage our resources, and we try to engage the other institutes so that they start addressing integration as part of their own research portfolios. So I think this is the way to do it. We can't do everything, obviously, at NCCIH, but we can inspire, I think, people to think in an integrative way.
Yeah, that's a really great point. Collaboration, it's always the answer.
Mm-hmm.
Speaking of collaboration, we have a question here about grants. So should a grant submitted for the June cycle highlight alignment with the soon-to-come strategic plan?
Sure. I mean, the strategic plan, we think, is going to be posted in May. If all goes well, we should have it out by our May council. And so it is perfectly appropriate to refer to the strategic plan in a June application. Yeah, absolutely.
Follow-up question, I'm thinking what they're asking is, what if they don't address the new strategic plan?
Well, the new strategic plan, we didn't throw out the old one, right? So, so the NCCIH is building upon our foundation of what we have done in the past. So in the past, there was a strong effort to understand, for example, and develop, understand mechanisms of, say, pain, for example. We had a strong interest in pain, which we continue to have, mechanisms, pain mechanisms, treatments, as I said, effectiveness, implementation. Natural products is another area, and then that's being wrapped into this nutritional category. But if you look at it, the natural products are still in there. The mind and body therapies that we used to call, where yoga, meditation, mindfulness, that's still in there. So the old strategic plan is there. All the content is there. It's just that we've rethought how we've organized it. So, and we've put more of an emphasis on the whole person health kind of framework. But there's really, we didn't throw out the content of the old plan. So you're fine.
Perfect. That's good to know. I'm sure they'll feel at ease now with their grant.
Oh yeah.
Grants are easy. Next question. What do you see as the biggest obstacle for complementary integrative health now? It's a big question.
Money. I mean, really, a lot of these therapies are still not reimbursed. And this is the problem. I mean, a lot of patients cannot afford them. So what do we need to do? We need to work really hard on developing not only the evidence base, but also work with for example, our partner sister organizations. We are currently, one of the grants that was funded through the HEAL initiative was in partnership with the Center for Medicare Services for coverage of acupuncture for low back pain in older adults. Now, this, importantly, this project is going to be used for evidence-based coverage determination. And so once Blue Cross and Blue Shield hopefully will start to cover acupuncture, then, once Medicare starts to cover acupuncture, other insurance companies like Blue Cross, for example, may follow. So I think this is very important that insurance companies need data. They need information in order to justify the reimbursement of these services. And that's what we need to provide. And we need to provide not only do the research, but disseminate it, make sure that people know about it. So that's really important.
I very much agree with that. We have a question here from Dr. Jonas. Will you be looking at the use of AI for salutogenesis in cancer? Seems like that might be low-hanging fruit.
Well, this is up to the investigators who want to. The AI opportunity, if you look on the website, is really about developing the databases and the structure, the infrastructure to actually do the artificial intelligence analysis. Whatever projects people want to propose to generate the kind of data that they want to generate, that's totally up to the investigators. The salutogenesis is one of the ideas, examples of the type of project it could be that's of particular interest to us at NCCIH. But there's many others questions that, of course, an approach like this could be used for. So it's a very exciting opportunity to really start answering, developing platforms to then be able to test hypotheses. But with artificial intelligence, the important thing is the data comes first. The hypothesis doesn't come first. It's kind of flipping things around. Usually when we do regular research, we start with a hypothesis and then we collect the data. With artificial intelligence, you start with the data, which is really interesting. And you have to collect the data in such a way that it can be used for artificial intelligence. The data has to be annotated properly. It has to be all organized in a very specific way. Then you mine the data, and then you can then use this to develop models to test hypotheses. So it's a very, very interesting approach that has a lot of potential for examining complex systems. And the complexity of health is, there's probably not too many things that are more complex than that. So it's really made for this. It's a very important, kind of opportunity to put the right tool to the right problem.
It is an exciting tool, and I know that's an NIH-wide priority, so hopefully that will be helpful as well. Another question about what the top priority for NCCIH is in terms of children's health.
Oh, well, we're very interested in, for example, emotional well-being in children, in schools, and well, across the lifespan. I mean, it's not, we don't have specific projects for children, but we're interested in the lifespan, the whole development of the lifespan, from childhood to young adulthood to older adults. And so, but especially for things like, for example, emotional and physical well-being. This is very, very important in making sure that children have a good start in life, and that areas that are creating stress in children, that we have ways to mitigate that. And because we know that, that this can have an impact for the rest of their lives in terms of creating what we call allostatic load. When children are exposed to a lot of trauma, a lot of stress early on, you can kind of develop sort of chronic stress responses that can linger on even after the stress has been removed. So it's very important to look at early life. So yes, we're very interested in this for sure.
A related question is, will you be looking at the youth and education for body literacy, health through whole health ed, and the youth participatory action research to see if we educate them about their bodies in a meaningful way early? Would something like structural equation modeling help us learn about the complexity? And that question is from Diane, who may need to provide more information.
Yeah, I don't know these particular modalities, but a lot of what it sounds like, it looks like it fits very well within the framework that I described. So importantly, I have to say, our strategic plan it's not going to say we're going to fund this and this and this and that. It provides a framework, and a lot of individual approaches, therapies, problems, hypotheses, they can, if they fit within the framework, then it's within our areas of interest. I mean, so the idea to read a strategic plan is not to go and look for one particular word or, oh, it's not in there, so they're not interested. No, it's really meant to kind of be a whole. So that's the right way to think about it.
So now a question about energy therapies, such as Reiki. Where do you put that in holistic therapies?
Now that's an interesting one. So, one of the areas that has been really, a little controversial in complementary and integrative health has been the areas of what we call energy medicine. And the research on this, I think, has been really lacking. I think that I would approach this from the point of view of methodology, just same way that we would recommend if somebody, for example, wants to do research on like an area that's still under development, like we haven't had a whole lot. I mentioned something like, for example, Ayurveda or traditional Chinese medicine. Well, I think energy medicine falls into that sort of category where we really need to understand, how do you study this? What is the right approach to understand kind of the right questions to ask? I would say for energy medicine, a specific important aspect is to say, what is the right question here? Is the right question, for example, to try to say, is there any, for example, evidence that if somebody does an experiment in a system of, for example, a plant or with cells in a culture dish, and you can determine that there's an energy, a form of energy that can influence this particular, in vitro system without any other, placebo effect or, much less complicated, that's a start. That's a really important start that can then be moved into, say, an animal model and then later into a human. That's really starting at the basic side. And then at the more whole person side, there's a lot of things that happen during an energy, what we call energy Reiki, for example, that may have nothing to do with energy, that simply have to do with a presence, like a human presence, kindness, directed attention, that are more in the psychological, realm. And those are very interesting as well and very, very important. So I think the important thing is to look at this from both ends. And before some of the problems, I think, is that people assume that there's an energy, or by meaning electromagnetic energy component to this, that there's no proof of that. So it's a hypothesis. And so they need to be tested. And so the idea is, how do you test it?
Hopefully we will see that testing in the near future.
Hopefully.
Question about opioid prescribing. Have you seen the push for patient satisfaction surveys affect opioid prescribing and addiction?
Patient satisfaction.
So I know Jeff, and I think I know what he's getting at there, is he's an ER physician, and when your patient leaves the ER, for instance, and they have opioids or don't have opioids, it may change how they feel that they were satisfied by the provider. Like, did they get what they felt they needed because they were in pain?
Yeah. I think Dr. Chase knows more about this than I do. So yeah, I don't know any research on this. Maybe there is that I don't know about.
Yeah, I think that there's been a little bit of research on that. I'm not familiar with it myself, but that's a great question, Jeff. And I think it's something we should certainly keep in mind when we're talking about whole health, because we do want to know what we are measuring and why we are measuring it. And patient satisfaction surveys certainly have biases inherent to them. Next question. Any thought to incorporating the recreation services and park services to offer services and education to help with physical services like walking programs, et cetera?
Yeah, that's really important. And I think this is an area where we're really excited to be collaborating with other institutes at NIH. For example, the National Institutes of Nursing Research and Environmental Health, where we really want to start. Remember, I had that multi-level diagram where we can really start looking at systems level intervention at the level of communities, and like in parks. What's the effect of creating a green space, or what's the effect of providing access to food, those types of systemic level interactions. What effect does that have on individuals? So yeah, I mean, it's a very important part of health. If you can't get outside to exercise, it's really a detriment to the person. So yeah, the answer is we're definitely interested in those types of aspects of health. We're also interested in the effects of green spaces in terms of multisensory input. If you were to go for a walk in the forest, for example, there's a lot of things. It's called a multisensory experience. You hear sounds, you see, the beautiful, green color, etc. And it's very soothing. But also, there's certain volatile chemicals that are sort of released by plants that may play a role in the sort of sense of well-being that you experience when you're outdoors in a natural setting. These could be really important as well. So there's a lot that we can understand about the power of nature in helping people to feel better and be healthier. Mm-hmm.
No, I'm personally very interested in that as well. We've done some forest bathing on our weekly mindfulness experiences, and it's virtual forest bathing, but it still felt good to see something that I don't have access to readily.
Interesting, just
yeah.
this thought, because we all have obviously memories that we can tap into of being in a space like that. So being reminded, because that's a lot of things when you do a meditation or a mindfulness exercise and you go to a place in your memory, you can recall some of this. So it has a lot of impact beyond the time that you're fortunate enough to be actually in the forest.
Yes, absolutely. We have a couple of minutes left, but I don't see any more questions. So if you have questions, you go ahead and throw them in the chat. We can have time probably for one or two more questions. But in the meantime, did you have any additional maybe thoughts that have popped up as we've been discussing that you wanted to add?
Well, I feel like the important thing is to people to understand that we want to just continue to be a dialogue, and we always welcome people comments. We have some blogs at NCCIH that you can write comments to. We want to keep in touch. Obviously, once it's not only during the strategic planning process. We want people to stay engaged, and you can do this on Twitter. You can do this on our blogs, and so there's a lot of ways that you can stay involved and let us know what is it that you're interested in. So, yeah.
And I follow both you and NCCIH on Twitter, and it is very valuable. So I can endorse that. If you all aren't using Twitter for science, you should be using Twitter for science.
Yeah, for sure. No, it's a great tool. It really, I like it too.
Excellent. Well, I think we are